And then the second speaker is going to be Dr. Daryl Goldman. She is a PGY6 at Mount Sinai Hospital. She did her medical school at University of Queensland and is finishing up her residency now at Mount Sinai. She has a clinical focus on neurointervention. And like I said, there's a lot of different pathways, and it's a very rapidly evolving field. So we should definitely try to pick her brain about how that's going for her.
So I'm going to give an overview today on stroke intervention. My name is Daryl Goldman. I'm a resident at Mount Sinai. I'm a PGY6 IR integrated resident, and I will be doing a year of neuroendovascular surgery next year as a fellowship. This is a new pathway, and if you guys are all interested in doing it, I'm happy to take questions at the end. I'm having trouble moving this. So give me 1 second, okay? Okay, can everybody see my screen and not see all of your faces in front of it? Just want to make sure.
Yes.
Okay, great. Okay. All right, so we're going to start with this is an overview and outline. We're going to start with the history of NIR and acute stroke. We're going to talk about some current guidelines, which are constantly training and very new and exciting. We're going to talk about what you need to know on diagnostic call as a diagnostic resident. And then we're going to talk about stroke and where it is at today, and then frontiers and the future of thrombectomy. So time is brain. So as you all know, so per stroke, there are 1.2 billion neurons lost. It's obviously something that happens very quickly, and it's per hour and per minute. So per minute, 1.9 million neurons are lost, and per second, 32,000. So obviously we have to act really quickly when we're going to intervene on these patients. Types of ischemic stroke. So there are several ischemic stroke classifications that we use. As you can see, there's TOAST, CIS, CCS, and ASCO. All essentially include large vessel atherosclerosis, cardioembolic, and small vessel disease, and then other is kind of sort of a large category, but primarily vasculitis is included there. So large vessel occlusion and some of the history. So occlusion includes occlusion of the intracranial ICA, proximal MCA, or the basilar artery. 24 to 46% of all ischemic stroke are large vessel occlusions. 80,000 LVOs annually in the US alone. So that's a large population at risk. There's 80,000 anterior and 20,000 posterior, and then about 10% of those are tandem occlusions, which include two different areas of occlusion, like the ICA and MCA, or ICA and other vessel, intracranial vessel. So how did we get where we are today? So I'm going to go over some of the history of this, which is long, so I'm going to go pretty quickly and skip over some of it. But in 2019, this is sort of our updated guidelines for early management of acute ischemic stroke, okay? We say that patients should receive mechanical thrombectomy with stent retriever, which is a little bit outdated at this point because we also use aspiration as well. And we include in these guidelines MRS, which is a patient's baseline function of 0 to 1. And then we talk about large vessel occlusion territories, which I spoke about earlier, which is, the ICA, M1 segment of the MCA, and then, as I mentioned previously. We also talk about the NIHSS score of equal to or greater than 6. And this is something that is changing currently, so I'll go into that when I talk about the future. We talk about aspects of greater than or equal to 6, and treatment can be initiated within 6 hours of symptom onset. And so again, this is 2019 guidelines, but it's changed significantly, and we're taking patients with a lot longer of a symptom onset window, okay? And we'll go into that also in my sort of future of our treatment discussion at the end, okay? So this is talking about the patients that we're taking up to 24 hours at this point in select patients, and I'll go into that more at the end. So this is a bit of a history. So in 1995, sorry, hold on a second. You have to go downstairs. I'm sorry. Give me 1 second. I'm having some baby problems. I have a 2-year-old. Okay. Yeah.
No problem.
Go find your dog. Okay. Okay. Give me 1 second. Sorry, everybody. Okay, everybody, I'm really sorry. I'm back. Okay. Okay. So, back in the very beginning in 1995, there was a trial on so intraarterial TPA. Okay. This was successful in opening up occlusion, but it led to a lot of brain intracranial hemorrhage, which they touched on actually in the PE lecture just a moment ago. And I'll go into that more as well. This was a multi-center prospective, double-blind, placebo-controlled, randomized controlled trial. They put IV RTPA for acute ischemic stroke, and it was given within 3 hours of symptom onset. It showed improved clinical outcomes, but mild increase in intracranial hemorrhage. So this is the reperfusion shown with IV RTPA, and it shows that in certain occlusions, it was more successful, primarily in distal vessel occlusions. And you can see that in the M2 segment of the MCA, it had about a 31 to 44%, you know, success in revascularization. And then as you kind of go more proximally and more specifically for ICA terminus occlusions, only 4 to 8% success in revascularization of those occlusions. In 1999, there was the trial, the PROACT-2 study, which looked at intraarterial prourokinase for acute ischemic stroke. This was a randomized control trial. And this trial showed a really a 10% risk of intracerebral hemorrhage for these patients. So this was something that was not considered, benefit over the risk of that. In 2008, this was the MERCY trial, and this was really the first trial that looked at mechanical thrombectomy for acute ischemic stroke. And it used the MERCY device, which you can see here in this picture, which was sort of like the first stent retriever, really. It sort of opened up in the vessel and kind of you could pull the clot out from the vessel. The MERCY device had a lot of risk really, and caused a lot of vascular damage to the vessel that it was used in. And there was a lot of intracerebral hemorrhage from this device early on. So in 2012, we have new tools, which is really exciting and kind of leads to this, huge influx of what we're doing today. The Trevo came out in 2012, and this was another stent retriever that we still use today. And it was a lot more gentle on the vessel. So there was a lot less, vascular damage that was caused and bleeding risk from that. So then in 2013, you see kind of a lot of trials start to come out on this. And then in 2015, this is the new golden age of interventional stroke. And there's a ton of trials, but most importantly, there's Mr. Clean, which really started to show that the benefit of endovascular therapy with mechanical thrombectomy really outweighed, was better than IV TPA alone. The big thing that trials from this sort of time period, Mr. Clean, Escape, Extend, Swift Prime, and Revasc AT really were showing us kind of our clinical guidelines for patient selection early on. So we talk about the MRS, which is a patient's, modified Rankin score, their baseline functional status, their NAHSS, and then we could kind of look at their, mortality risk benefit based on these kind of preclinical indicators. We talk about we got our sort of time window from this for when treatment was beneficial for these patients versus when it was, increased risk. And then we were able to sort of exclude based on our CT aspect score as well. And we were able to improve our techniques from these early trials. So now in 2017, we started to push the boundaries of thrombectomy. We start to increase our time window. So it was used to be when patients presented with an LVO, it had to be within 6 hours of last known well, had to be within 6 hours of treatment. And now, we're actually today extending that time to up to 24 hours even, which is pretty amazing. And those trials are still underway. So the current guidelines, which I showed briefly, these are in 2019. These are the guidelines that we still have, but these are really out of date even today, right? Because they talk about NAHSS over 6 and aspects less than, greater than 6. They talk about treatment window within 6 hours, and this is all outdated at this point. All these trials now have showed that we're treating patients up to 24 hours at this point. We're also treating patients with low NIHSS, less than 6, so that's pretty amazing as well. And I'm just gonna fly through this a little bit because I'm gonna be out of town because I had a 2-year-old interrupt me. Sorry about that. So the decision making in acute LVO, this is really important and something that you need to know if you're going to be doing stroke care, obviously. So we want to know their age, their last seen normal or the last known well, their NAHSS, their functional status. Are they a candidate for lytics? So now it's, within 4.5 hours of onset. If they present, then they'll get TNK typically at most places or TPA. We look at their non-con CT to see if we can tell if there's, a large core that has already, a lot of brain that's already dead, or if there's some that's at risk that's still salvageable. We look at their CTA and we look at their CTP. So the NIH is the gold standard neurologic assessment, right? It has 11 discrete parameters, which you guys can look at, but it's good to familiarize yourself with this NIHSS score and really know how to do it on your patients yourself. The MRS, which is the modified Rankin score, this gives you an idea of somebody's baseline clinical status. So if somebody's like bedbound or, then we might not necessarily take them for thrombectomy because their benefit of intravascular revascularization is not really going to, these patients also, don't really recover well from a stroke treatment. So imaging, we talk about aspect score. We look at, again, like how much brain is already dead, what part of the brain is dead. And aspects really applies really to just the MCA territory, but we can look at the PC aspect score, which looks at posterior circulation stroke as well. So this used to be true, but we used to kind of look at the acute window rule of 6s, which helped us all clinically triage these patients. But this is, again, sort of outdated at this point. And it depends what center you're at. A lot of centers, it's not outdated and they're still doing this. But some centers that are, really responding to these new clinical trials that are coming out are, again, taking patients with lower NAHSS, more distal vessel occlusions are being, treated, and also patients that are, up to 24 hours from onset of symptoms. So let's get into a little bit of the technique. Obviously, vascular access, arch access, advancing the system and removing the clot. We kind of go through patient risk factors, their pre-hospital team. There's a huge team kind of involved with this. We work very closely with the stroke neurologists. We work closely with, neurosurgery, obviously, if somebody's at risk for a bleed. I'm going to kind of I can send you my slides if you want, but this is kind of more basic. But really what is interesting is looking at the arch. Always look at the CTA. You want to know what kind of arch you're dealing with and how easy it is going to be to get up to the intracranial circulation. We have various different catheters for arch selection, which can help. And we have various different stroke catheters that we use that can also help access the intracranials. We use microcatheters as well. We use aspiration. And we use sort of a triaxial system, which includes like a large guide, intermediate catheter, and then our aspiration catheters through that. Or if we're using a stent retriever, that goes through a microcatheter. But there are three basic techniques. There's like the stent retriever technique. There's multiple different, types of stent retrievers that we use. There's the adapt technique, which is using aspiration, and then there's a combined. You can see kind of a schematic of that there. Oh, it went back. 1 second. So the evolution of stroke thrombectomy techniques to optimize first pass complete perfusion. So this is kind of a long sort of history as well. But basically, a lot of people use a combination of aspiration and stent retriever, I would say. And some people use one or the other first, and some people use the other, and some people use combination, where you use a combination of the stent retriever and then have secondary aspiration as you pull that clot back. The TICI score is something we use when we're evaluating angiographic outcomes. And so we say, 0 means that we didn't get the clot out at all and there's still complete occlusion. 1 means that we, see some penetration with some minimal perfusion. 2A is partial filling. 2B is complete filling. And then 3 is a perfect, reperfusion to that area. So this is an example of a right M1 MCA occlusion. And you can see that there's really no contrast going past the M1 segment of the MCA, and then on the other side, the other panel, you can see that there's complete reperfusion of that MCA territory, and that would be a TICI 3 result. How much time do I have?
About
Hey,
wrapping up.
Goldman. Yeah.
Out of
We do have
time?
Dr. Sista to say. Yeah, we are technically out of time. We do have Dr. Sista to talk. However, we
Okay,
did have a little
great.
bit of time left over at the end. If you did want to stay and do a couple more after
Okay.
Dr. Sista's presentation, that'd be awesome. I also know
Okay.
that you have a 2-year-old, and that's totally appreciated. So whatever works best for you.
Sorry, everybody, she got away from the nanny,
No, don't be.
apparently.
No, you're
problem.
doing
Thanks so much.
thrombectomies and mandling toddlers. That's pretty impressive.
Okay. Well, thank you for having me. Next time I'll have 2 nannies. Okay.
Absolutely. It was a pleasure.
Okay. All right. Bye.